Hello everyone. In the next few minutes, I would like to take you all through a case of LASIK flap tear which was managed successfully at our center. Susceptibility of eyes undergoing LASIK to trauma in any form deserves a special attention. Flap-related complications following trauma range from flap dislocation to flap amputation. Late complications include epithelial ingrowth and diffuse lamellar keratitis. These have been reported as early as 10 days to as late as 14 years post-LASIK. Flap adherence in early postoperative period is mainly due to capillary action, fibers interlacing, intracorneal suction, endothelial pump, and ionic bonding. However, mechanism of action of adherence in late postoperative period remains unclear and the flap tends to never heal. Common etiologies reported in literature include injury with fingernail, trauma with dog's paw, airbag injury, injury sustained during sports activity, with a tree branch, with the edge of paper back, during gardening, or during domestic repairs. So, with this background in mind, let us move on to a case. My patient was a 24-year-old gentleman who sustained injury to his right eye while hammering nail against the wall. Nail flew back and hit his eye. He had undergone LASIK 8 months back, which was uneventful. Rest of his history was not contributory. Visual acuity in right eye was 6/24 and left eye was 6/6. On slit lamp examination, right eye had conjunctival congestion. Cornea had a localized flap tear around 7 mm involving the pupillary axis, but not reaching the flap margins. There were interface debris. However, the underlying stromal bed was not involved. The rest of the LASIK flap was unaffected and well placed. Rest of anterior and posterior segment examination in both eyes was essentially within normal limits. Hence, a diagnosis of both eye status post-LASIK and right eye flap tear post-trauma was made. At this point on time, our plan was right eye interface wash to remove the debris plus flap tear repair. We took him up for the surgery on the same day. Let us look how we went ahead with the surgery. Thorough wash was given to remove dust and debris. At this point in time, we had a dilemma whether to suture the flap, which could induce astigmatism in visual axis, or just go ahead with simple apposition with a lingering thought, will the flap remain attached? Let us see how we proceeded. Flap edges were then examined after few minutes. They remained very well opposed, and hence we decided not to suture. A bandage contact lens was placed at the end of surgery. It served two purposes: additional protection from displacement, and it increased the patient comfort. On postoperative day 1, his visual acuity was 6/12. Well opposed flap edges with minimal edema. There were no striae or no cellular reaction, and rest of the flap was well placed. He was started on antibiotic and steroids in tapering doses. 1 month post-op, patient regained his visual acuity of 6/6 uncorrected, and so far there was no evidence of epithelial ingrowth or diffuse lamellar keratitis. Thus, we were able to get away without sutures and without inducing astigmatism in visual axis. Let us see what had actually happened at microscopic level, keeping these two edges opposed. So, keratocytes near the wound edges undergo apoptosis after injury. This signals the peripheral keratocytes to undergo differentiation into fibroblast and subsequently to myofibroblast. Myofibroblasts lay down provisional extracellular matrix and generate contractile forces in an attempt to close the wound, hence keeping the edges of our wound opposed. Thus, to recapitulate whatever we have learned through this case, displaced or subluxated flap requires immediate attention in the form of flap repositioning. Careful interface wash should be given to remove all debris. Base should be examined for presence of epithelial swells, especially in cases of late presentation. Careful apposition of flap and realignment will minimize irregular wound healing. We should try to eliminate all the excess fluid from interface as well as flap edges. This can be done with the help of surgical sponge. A bandage contact lens provides additional protection from further displacement. I thank you all for your patient listening.